Dr. Suvira Jain, speaking on Litmus test of patient satisfaction.
1, 2, 1, 2, 3, 4.
Unlike Michael Jackson, however, I do think it's actually important whether the patient actually chooses dark or white glasses at the end of surgery, because it would be fairly challenging to expect a post-cataract patient to see clearly with dark, non-numbered glasses for an entire month. But how does one then create this mindset shift in an entire institute to make them understand this simple truth? Good afternoon, ladies and gentlemen. I stand before you today not to impress you, but to impress upon you what it took for us to change our Trust Eye Hospital in Mumbai to one that today offers the highest level of patient care and a customized cataract surgical experience to all its patients. Now, the first thing that I understood very early on is that man's fundamental instinctive need across continents, races, and ethnicities is to provide for his family. And not only that, he's going to provide the very best he can. And that's what got me thinking, why are we not promoting premium lenses so much more than we really could be in our practice? Moreover, being a hyperopic presbyope, once whilst in the kitchen trying to make myself a cup of tea, I mistook mustard for tea leaves, and that again got me thinking, what are the limitations of intermediate and near work in the daily life of a presbyope as well as of a monofocal pseudophakic? And that's when I thought that this is the kind of range of vision I'd like to incorporate via the lenses that I'm incorporating in patients' eyes. The challenge, however, was now, how do I convince the entire lot of the senior staff doctors who were in the management, the junior doctors and my colleagues who were seeing patients, and the counselors who were busy discussing IOL options with them? In fact, to actually get the counselors to change the old tariff sheet to the new one, which now had the entire array of lenses which I had understood and wanted to use in my practice, was an even bigger ordeal in itself. To the counselors, they thought that the patients would actually be intimidated. Oh my God, patients are going to think, how expensive is this? And they would just go away. But I thought singularly was of that opinion that the patients would actually look at it like how many more options they now had, which were even better and were likely to give them a better outcome. The truth, my friends, is always subjective, and it is a matter of perception. Anyway, the other important factor I realized that the one commodity each of us needs to seriously invest in is that of time. Time to be able to understand what are the patient's preferences, his lifestyle, his ambient illumination, very important. What are the things he likes to do? Time to be able to discuss lens options with the patients, not only the imported, but definitely the Indian multifocals of the Appasamy as well as the IOCare, which do so brilliantly well. Time, very importantly, to make them understand what were the limitations of the lenses, so we were able to always, at odd points, set up realistic expectations, and time to talk to them a little bit more about perioperative care. The aim of this entire consult was to be able to establish a firm connect between you, the operating surgeon, and the patient himself. So how did we pull it off? At the foremost, we needed to have a firm conviction in the idea, and I was sure that I could make this work. Second was trying to gain an in-depth knowledge about the subject at hand. And despite everything else, what worked most for me is discussing with my peers who were already majorly into practice using all these premium lenses, and I paid close attention to detail about their results. And finally, ensuring you have a skill set that gave you consistently good results. Finally, now we also realized that now when we decided we're going to go ahead with it, we realized we cannot go wrong with IOL power calculation until we could incorporate a optical biometer in our practice, which we did a couple of years ago. We'd sent our patients to get it done at not so much of a price. And surgery, of course, we needed to make sure that almost always, I say almost always because once in a while we all do have complications, almost always your surgery was clean, uncomplicated, uneventful, and consistent. Now, the post-op evaluation included evaluating the visual resolution. Now, visual resolution is evaluated, we all know, using the Snellen acuity. But we need to understand that the Snellen acuity works at a fixed contrast of 94%, which is not what we face in our day-to-day living. So we have to incorporate evaluation of the contrast sensitivity. And this is what we procured. We got the Mars contrast sensitivity chart. It's a simple test to do. We can do it in all our outpatient departments. You just need a patient wearing his distance and ear correction in place, one eye at a time, holding the chart at 60 meters. And the only prerequisite is getting your ambient illumination to a fixed amount of about 260 luxes, which is very simply done with a lux meter that comes along with it. And finally, evaluating the third aspect of visual resolution was evaluating the range of vision. Now, this, I thought, is again an important topic to talk about, so just speak a couple of minutes about it. So we all learned how to, and then started plotting the defocus curve. Now, the defocus curve is an objective way of evaluating the patient's range of vision by evaluating his visual acuity at different distances. It works on the refractive principle that f is equal to 1 by d. So what that means is, for a patient to see clearly at 1 meter, you need to have one diopter accommodation. So also, for a pseudophakic patient to see clearly at 1 meter, there needs to be a +1 add effect in the IOL. And therefore, you can work it out, where am I? Therefore, you can work it out for all the different ranges. To see clearly at 66, there needs to be a 1.5 add. You can even read it the other way. So if a patient can see through a defocus of 2.5D, it means he sees clearly at 40 centimeters. A simple concept, very easy to do, just takes a little bit of understanding. And how is it plotted? Oh, OK, sorry. How it is plotted is you just have a graph. And as you can see here, let me try this. OK, sorry. OK, so, all right, OK, I'm going to go without it. If you can see where the 0 is, the patient sits at the normal distance where you're checking the Snellen acuity, and he has his distance correction in place. And after the distance correction is put in place, you progressively add minus 0.5 increments. You keep adding lenses and see how clearly can the patient see. So with the monofocal lens, you'd get a graph that appears like this. With a multifocal lens, you'd have a bifid pattern with a drop in the area of the intermediate. And with extended depth of focal length or a trifocal IOL, you would get the ability to see in a sustained manner clearly from distance to up to 30 to 40 centimeters. So much for the post-op evaluation. And then what is it that stops us, and where is it where we are inhibited in using premium multifocal lenses? Because we are concerned about patients being unhappy. Now, we need to realize that despite the most detailed counseling, the most meticulous planning, and the most perfect surgery that you can offer a patient, you sometimes may have a patient who is unhappy. Now, if he's unhappy, it's most likely, if everything else has gone right, it's most often that he perceives something a little different from what he expected. So your counseling needs to be very good. Now, if I have a patient who comes to me who's unhappy, I make sure that my team of doctors, some of whom are here, they work them up fully again. We make sure we've not ruled out things like dry eyes. We look for, is there a surgical ametropia? Have we got a residual spherical or a cylinder? Does he have suboptimal scotopic vision? Have we fallen short with our range of vision, either for near or intermediate? Is there a posterior capsular opacification? Is there a CME? Once I've had that entire workup done, I then meet the patient, and that's what's very important now is your attitude towards your patient. You can't tell him that everything's OK, I don't know what your problem is. In fact, if you approach the patient, which I always do, is that, OK, something doesn't seem to be right. Let's see what we can do to fix it. Having this approach to the patient automatically gets him to drop his guard, and you two both together can go ahead and sort out the issue at hand. Sometimes, however, you may be left with a significant refractive surprise, and you may need to do something about it. So you've got to be equipped with the surgical know-how of how to explant a lens, which I think, after fixating it, with one hand. You need to be able to cut it through from one end of the optic haptic junction to the other, bring one out, and then the other out. You don't need an incision to be any more than 3 millimeters for the same. But that might be fairly challenging. Oh, sorry. And suppose you found it to be challenging as, no, I'm sorry. Just let me go back. Can we just go back to that slide, please? Yeah, that one. Thank you. Finally, OK, so this is how you explant a lens. But sometimes this can be fairly cumbersome. I've tried a lot of intraocular forceps, but I finally find that a fine-tipped long varnish does the job better than anything else. But other than this, you also have an option of now using an add-on lens from the IOK company. The company people are very good at helping you work out what is the residue of the spherical and what is the residue of the ad that you need on, and this is how it's done. So this patient fell short with his ad effect, and this is how add-on lens can be very simply, after ensuring that the sulcus is clear, very easily all 4 haptics can be put in place. You ensure the centration by looking at the first and third Purkinje image, and everything then is fairly easy. And finally, if you're putting in a toric IOL, you need to be able to rotate a misaligned toric IOL into its correct position. So these are the 3 things you need to do. So here's a smart toric lens. The truth is that the surgeons forgot to mark the 0180 before surgery. And we forgot, and that was a mistake we made. So all you needed to do is go back in there and literally just turn the lens into a 0180 position, and your results are absolutely bang on. And finally, in conclusion, I'd like to add, is success and progress only measured by being able to promote the most premium of IOLs and the premium of technology in our practice, with a view to improving practice, making big money, and having a big name? I think not. I think to me today, it is about honoring each and every patient who comes into your OPD, no matter who, treating him as a whole, and doing whatever you possibly can to give him the best outcome possible, with a view to giving him the most perfect visual outcome that may be possible, and leaving him completely satisfied with his experience. And to me, ladies and gentlemen, the litmus test to patient satisfaction is a smile that says it all. Thank you.